So now we're going to discuss fractures and the different ways that our bodies can repair them when they occur. Fractures are just breaks that occur in our bones, and they often will occur due to some type of excessive stress or strain that has been put on a bone. Fractures are very common clinically, so it's important that our body has a way to repair fractures when they do occur. So you'll see over here that there are a few phases to fracture repair. In fact, there are 3 phases, but one of these is going to have 2 different subphases within it. So let's discuss each of these. First is the reactive phase. This is characterized by our body reacting to the fracture. This is the first reaction to the fracture that has occurred. We have the reparative phase, where our body is going to start repairing. And there's 2 subphases within this, namely the fibrocartilaginous callus formation and the bony callus formation. Each of these are 2 phases which make up the reparative phase. And lastly is the bone remodeling phase, where we're actually going to put the finishing touches on this bone repair. So let's discuss these phases and see what happens during each. So first is the reactive phase. The reactive phase is our body's first reaction to the fracture that has occurred. So when bones get broken, that's going to damage a lot of the tissue inside of the bone. Remember, bone has a very, very rich blood supply. So when we break bone in some place, we're going to damage blood vessels in there as well. And the breaking of these blood vessels is going to cause blood to flow out and form what is known as a fracture hematoma. That's this very large blood clot that can be seen around the sides here. So nearby bone cells are dying and inflammation is occurring in response to those dead bone cells. Since inflammation is occurring, that's bringing lots of phagocytes to this area, and those are going to end up removing some of the damaged tissue around the fracture hematoma. So our reactive phase is our first phase, which brings a lot of reparative cells to the area, and we're going to start forming this blood clot to stop the bleeding, and then that's going to take us into our next phase, which is the reparative phase. Now remember, the reparative phase is made up of the fibrocartilaginous callus formation and the bony callus formation, 2 subphases within this same phase. So we could also call the fibrocartilaginous callus formation the soft callus formation, and we can call the bony callus formation the hard callus formation. So after a few weeks, blood vessels are going to grow back into the fracture hematoma, and those phagocytes are going to start cleaning up dead bone cells. We'll also have fibroblasts that are migrating to this area, and those are going to produce collagen fibers, which is the major component of our soft callus. Chondroblasts, which are cartilage cells that will secrete the extracellular matrix of cartilage, will also be migrating to this area, and they're going to produce fibrocartilage around the bone. So this is why we call this the fibrocartilaginous callus formation, is because chondroblasts are coming to this area and producing a layer of fibrocartilage around where we used to see the fracture hematoma. You can also see these new blood vessels have grown into this area, and we're going to start vascularizing this fibrocartilaginous callus as well. So this is what's going to occur immediately after the reactive phase. Now there's also this second part, which is the bony callus formation. In this phase, osteoblasts are going to be the major player. Osteoblasts are going to start producing spongy bone around these areas. They're going to start making new bone along where the fibrocartilaginous callus was found. And they do this by converting the fibrocartilage to bone. So we take the fibrocartilage that was here and we use that as a model to make new bones in the bony callus formation. So the last phase of fracture repair is the bone remodeling phase. This last bone remodeling phase is characterized by the formation of compact bone on the outsides of our bone. Remember, we have this layer of compact bone on the outside and spongy bone on the inside. So that spongy bone that was formed during the bony callus formation is going to eventually turn into compact bone, and then our osteoclasts are going to start cleaning up the sides, and this is going to return our bone shape relatively back to normal. So in summary, for the phases of fracture repair, we have the reactive phase that occurs first, the reparative phase that occurs second, and there are 2 subphases that occur within the reparative phase, and then lastly we're going to have the bone remodeling phase. So some of the major events that will occur during each of these phases, in the reactive phase, we're going to have the fracture hematomal formation. And there's also a lot of inflammation occurs, and that's what allows for these other cells to come into this area and start the repair process. We also will have the reparative phase occurring right after that, and we have 2 subphases, the fibrocartilaginous callus formation and the bony callus formation. The fibrocartilaginous callus formation is characterized by fibroblasts and chondroblasts and their activity. Fibroblasts are bringing in collagen fibers, chondroblasts are bringing in fibrocartilage. And this is forming that fibrocartilaginous callus around that area of the fracture line, and we'll also have those blood vessels growing in during the fibrocartilaginous phase as well. There's going to be a lot of blood vessel repair. The bony callus, or the hard callus, is going to be the next phase, where osteoblasts are the major player. Osteoblasts are taking that fibrocartilage and turning it into spongy bone trabeculae. So they use fibrocartilage as a model. The last phase is the bone remodeling phase, where that spongy bone is going to be turned into a layer of compact bone. Now this only occurs around the periphery of our bone, on the sides of our bones where compact bone is supposed to be found. We won't have compact bone found all throughout the bone. Instead, we'll have that spongy bone remain in those other areas. So these are the phases of fracture healing, and now we're going to discuss some of the different types of fractures that we will often see clinically. So there are 6 types of fractures that we're going to cover. The first type is an open fracture, and it can also be called a compound fracture. Open fractures are defined as some type of fracture that has allowed bone to protrude through the skin. I like to think of open fractures as a type of fracture that has opened up the skin. So if you can see the bone in the clinical scenario, this is going to be an open fracture. We also do have closed fractures, and those will not break the skin. So some heavy impact to the diaphysis of our long bones can often cause this type of fracture. We'll also see a comminuted fracture. Comminuted fractures are when part of our bone has been crushed. You can see in this picture we have a lot of little pieces in our bones. There's two major ends of the bones, but there's this center portion that has been crushed or splintered. And there's lots of different pieces in here. So this is a comminuted fracture. Comminuted fractures will not necessarily break the skin. So again, we classify these fractures differently. Open fractures will break through the skin. Comminuted fractures will produce splintering or broken pieces of bones with 2 larger ends on either side. We will also see a green stick fracture. The green stick fracture is appropriately named because this type of fracture looks like a twig that has been broken at one end and is still attached at the other. These types of fractures will more commonly occur in children because the bones in children are not fully ossified and still have a little bit of give to them. So a green stick fracture is where there's some type of impact to the bone that breaks one side of our bone but not the other. You can see here that this outer portion has been broken, but the inner portion remains attached. And this inner portion ends up bending, which is only occurring because the bones have not fully been ossified. And that's why we see this occurring more often in children. So if you were to take a branch from a live tree and you were to break it, the far end would end up cracking and separating. However, that inner end is going to bend. And so that's where we get the name for the green stick fracture. An impacted fracture is going to occur from some type of force pushing our bones along its longitudinal axis. This causes one end of our bone to be forcefully pushed into the other end of our bone. One thing that you can see is a lot of these fractures I'm showing you occur with long bones. Because long bones are, by definition, much longer, there's more of a likelihood that those bones will have these different types of fractures. So these are 2 other fractures that tend to be a little bit more specific. The Potts fracture is specifically a fracture that occurs at the distal end of the fibula. The fibula is the bone that can be found on the lateral side of the lower leg. We can see that bone here. So when the distal end of this is broken, we call that a Potts fracture. This fracture is a little bit more specific than some of the other ones we've mentioned, but I would still like you to understand that this fracture occurs specifically with the fibula. We also will have the Colles fracture, which is similar to the Potts fracture, but this occurs at the distal end of the radius bone, and this is found at the lateral side of the arm. So both of these bones are found laterally when in the anatomical position, and both of these fractures refer to a break that occurs at the distal end of that bone. So this is the Potts fracture and the Colles fracture. The Potts fracture occurs with the fibula, and the Colles fracture occurs with the radius. Now the next major topic that I'm going to cover is bone remodeling. Now through chapter 6, I've really been talking quite a bit about bone remodeling, so let's dive in here and see what bone remodeling is all about. So I said in the last lecture video that bone remodeling is always taking place. Our bodies are always forming new bones and breaking down old bones. We're always trading out new bone tissue with old bone tissue. And so bone remodeling can nicely be described as the balance of osteoblastic activity with osteoclastic activity. Remember, osteoblasts build bone and secrete bone matrix, while osteoclasts are going to break down bone. They will crush bone. So when these two cells work together, osteoblasts are going to be forming new bone matrix, and osteoclasts are going to be breaking down old bone matrix. Now this doesn't mean that we're breaking down entire bones and then adding whole new bones. This is a much more subtle process. But at the microscopic level, this will always be occurring. So one other way that we can describe bone remodeling is the balance of bone resorption with bone deposition. Bone resorption is what our osteoclasts do. Osteoclasts will crush bone and break it down. So the way that they do this is by releasing certain enzymes to the bones, which will help to remove minerals from those bones and release them into the bloodstream. So osteoclasts will take osteoid and essentially destroy it. Now osteoblasts are going to have the opposite function. They are secreting bone matrix and building new bones. So osteoblasts are responsible for the process of bone deposition. They are putting more bone matrix into our bones and making our bones a lot harder and stronger. So just as we saw with bone formation and how our bones thicken over the years, osteoblasts are going to be depositing new bone and osteoclasts are going to be breaking down old bone. Now this process is going to be extremely important for our body's calcium homeostasis. And I mentioned in our last video that this process is also important for the growth of our bones. Now the rates of bone deposition by osteoblasts and bone resorption by osteoclasts are going to differ throughout our lives. When we're younger, bone deposition is going to outpace bone resorption. When we're younger, we're adding more bones and that's helping our bones to grow. Both of these processes will occur in the same amounts when we are in adulthood. However, when we get to old age, bone resorption is going to start outpacing bone deposition. And this is when we get at risk for conditions like osteoporosis. So this is why it's so very important for us to feed our bodies and our osteoblasts with what they need to form bone matrix when we are young. One other important statement to mention about bone remodeling is that areas of our bones that are susceptible to stress have the ability to become a lot stronger over time. And we can apply this concept to our muscles and tendons that are attaching to bones. Muscles attach to bones through tendons, and when muscles contract, they're pulling on the tendons that are in turn pulling on the bones in certain areas. These areas that are attached to tendons are going to be very susceptible to stress over the course of our lives. And so these areas of our bones that have a lot of stimulation from tendons will actually in turn stimulate osteoblasts to secrete more bone matrix in those areas. So exercise and physical activity will actually help to make stronger bones. Now the skeletal system is also going to play a very integral role in our body's calcium homeostasis. Bone is our body's major calcium storage site in the body. And it's not only a storage site, but it also serves as a calcium reservoir. So if we need more calcium in our blood, we can break down bones to release that calcium into the blood. And if we have too much calcium in the blood, we can send that into the bones. And this is done thanks to our osteoblasts and our osteoclasts working together. Now, just like with the rest of our body's controlled conditions, blood calcium has its own homeostasis, and it needs to remain within very, very specific limits at all times. Specifically, our plasma level of calcium needs to remain between 9 and 11 milligrams per 100 milliliters, which is a very, very small amount. So again, if we go too low, we're going to need to have some mechanism by which we can bring our blood calcium up, and if we go too high, we need to have some way that we can bring our blood calcium down. So our bodies have a few mechanisms by which we can control our calcium homeostasis. The major hormone that our body uses to increase calcium levels is parathyroid hormone. When calcium levels drop, the parathyroid gland, which is one of our endocrine organs, is going to release this parathyroid hormone. Parathyroid hormone has a few actions within the body, but it's primarily going to function to increase calcium levels when our blood calcium has decreased. Parathyroid hormone has a few ways of doing this, but ultimately it's going to increase calcium levels. So parathyroid hormone is going to act on osteoclasts and also on the kidneys, and both of these will have different mechanisms by which we are saving calcium and keeping calcium in our bodies. So the first way is by osteoclasts. Osteoclasts are going to be stimulated by parathyroid hormone to increase their activity. Remember, osteoclasts break down bone and release calcium into the bloodstream. So if we stimulate osteoclasts to pick up this activity, they're going to release more calcium into the bloodstream, and that will help to return our calcium level back to normal. But this is not the whole story. We also have the kidneys playing a role in here as well. If you can briefly remember from when we discussed the integumentary system is helping us to produce vitamin D. That is one of our functions of the integumentary system, vitamin D synthesis. And vitamin D's major role is to bind to calcium to help us absorb calcium. However, the integumentary system is not the only system that can produce vitamin D. Parathyroid hormone will also work on the kidneys, and this will ultimately help to increase calcium absorption because we'll have more vitamin D to facilitate its absorption. So this feedback loop is shown right here, and this example shows us what happens when our calcium levels have decreased. So some type of stimulus is going to reduce our controlled condition, which is blood calcium. When blood calcium is reduced below 9 milligrams per 100 milliliters, cells in the parathyroid gland are going to respond to this. These cells are serving as the receptors for our blood calcium levels. And when these cells detect that calcium has been lowered in the bloodstream, they're going to produce a molecule known as cyclic AMP. This is a common molecule that we see in the body that serves as a chemical messenger. And this cyclic AMP is going to make its way all the way to the parathyroid hormone gene inside of our parathyroid hormone cells. Cyclic AMP's effect on the genes of our parathyroid hormone cells is to increase the production of parathyroid hormone. This molecule, cyclic AMP, is going to turn on that gene so that we can create more parathyroid hormone. And when more parathyroid hormone has been released into the bloodstream, it's going to make its way over to our osteoclasts and the kidneys, and it will have two different functions. Remember, parathyroid hormone is going to stimulate osteoclasts, and this will increase bone resorption. Osteoclasts are breaking down bones, so they're going to start breaking down more bones and release that calcium into the bloodstream as one mechanism by which we can repair our already lowered blood calcium. The other mechanism is by affecting the kidneys. Parathyroid hormone tells the kidneys to retain calcium. Our kidneys work as a filter, and it can control the things that it filters in and out of the body. So calcium levels can also be increased by stimulating the kidney to retain calcium in the blood. And both of these mechanisms together will help to repair our blood calcium back to a normal level. This is an example of a negative feedback loop. So when our blood calcium levels are decreased, we're going to see this feedback loop. But what happens if our blood calcium level goes too high? What if we go over 11 milligrams per 100 milliliters? And that is where we see calcitonin come in. So parathyroid hormone functions to increase blood calcium, while calcitonin is actually going to decrease blood calcium. So when blood calcium levels are decreased, we're going to call on our parathyroid gland cells to release parathyroid hormone. However, there are other cells in the body that are going to release a hormone known as calcitonin. Calcitonin is going to have the opposite effect as parathyroid hormone. This is going to inhibit osteoclasts. So osteoclasts will no longer be breaking down as much bone, and it will speed up bone deposition by stimulating osteoblasts. So there are many mechanisms by which we can control the homeostasis of our bodies, and these are two ways that we can specifically control our body's calcium homeostasis. Parathyroid hormone will increase blood calcium, and calcitonin will decrease blood calcium. Now, as I mentioned a little bit earlier when I was talking about bone remodeling, bone deposition and bone resorption will occur at different paces throughout life. So, from birth through adolescence, bone deposition is going to be a more prominent process than bone resorption because we're growing and we need to add more bones to our bodies and elongate bones and thicken our bones as well. So in early life, we're going to have more bone deposition than bone resorption. Bone deposition will outpace bone resorption in early life. In adults, those rates are going to be relatively the same. We're going to have the same amount of bone resorption with the same amount of bone deposition. However, this is going to be set off when we get into our older individuals, especially postmenopausal women. This is a group that is very, very susceptible to obtaining osteoporosis. So when we're older individuals, when we become a little bit older, bone resorption is actually going to outpace bone deposition. So we're actually going to be breaking down more bone and removing bone matrix from our bones more readily than we did whenever we were younger. And there's going to be a lot less bone deposition occurring as well. So the result of this is that our bones are going to become weaker over time. And this is what puts us at high risk for osteoporosis. Again, especially this condition, osteoporosis, is very common in postmenopausal women. And you can see from this picture that this bone is just looking very, very frail and very, very weak. This is what normal spongy bone trabeculae are going to look like when they are properly formed. And with osteoporosis, you can see that these trabeculae have just become much, much weaker. And so osteoporosis, weakening our bones, is putting us at risk for a lot more fractures and damage to our bones. So this can be a real issue, and this is why it's important for us to have a good balanced diet and exercise regularly. Now, there are a lot of factors and components that we can find in our bones, and I'm not going to harp on this slide too much, but I just want you to know that calcium and phosphorus are going to be two of the major components that help make our bones very hard. They make the extracellular matrix, that osteoid of our bone, very, very hard and firm, which makes this a very supportive type of connective tissue. So again, applying the concept of osteoporosis, if we're not depositing new bone matrix, that's going to make our bones a lot weaker. So the one thing I want to mention on this slide is that vitamin D is a major player in calcium absorption. This is activated in the integumentary system, and when we eat calcium, vitamin D is going to bind to it so that we can absorb it. If we don't have vitamin D, we can't absorb calcium into our bodies, and it's just going to go straight through the digestive system. So vitamin D is vital for our skeletal system to have enough calcium that will be sufficient for our bodies. And once again, I know this slide has a lot of information, but I just want to direct you to parathyroid hormone and calcitonin at the bottom. Calcitonin is going to inhibit the resorption of bone by osteoclasts, and this is going to help to decrease our blood levels of calcium. And parathyroid hormone is going to be working the opposite by promoting bone resorption by our osteoclasts. They are going to break down more bone matrix and release that calcium into the bloodstream. And that will ultimately increase calcium levels. And this will also act on the kidneys as well to make more vitamin D. So just to mention this topic one more time, certain physical activities will help to build thicker and stronger bones. Remember, our muscles attach to bones through tendons, and when we're pulling on those tendons, that's going to stimulate osteoblasts. And ultimately, osteoblasts, when stimulated, are going to secrete more bone matrix, and that will help to form thicker and stronger bones. And the stronger and thicker our bones are, the less chance that we're going to get osteoporosis when we get older. As we age, sex hormone concentrations are going to decrease, and that will eventually cause bone resorption to outpace bone deposition. And this is what causes the weakening in bones as we age. Ultimately, with this bone resorption outpacing bone deposition, we're decreasing our overall bone mass. And the less bone mass we have, the more frail our bones are going to become, and the greater chance we have of getting some type of fracture. Now lastly, for Chapter 6, I just want to touch on two clinical conditions that we will see that are related to our bones. Those two conditions are rickets and osteomalacia. So both of these conditions are fairly similar. One occurs in children and one occurs in adults. But what both of these conditions do have in common is that they both refer to an inadequate calcification of our bone matrix. One of the major reasons that we might have inadequate calcification of bone matrix is a deficiency of calcium. And what might cause a deficiency in calcium is a deficiency in vitamin D. If we don't have enough vitamin D to absorb calcium into our bodies, we're not going to have enough calcium to put into our bones and make our extracellular bone matrix very hard and firm. So one of the major causes of this is in fact vitamin D deficiency, because without vitamin D we can't absorb calcium, and if we don't have calcium we can't make strong bones. So rickets is the condition that we will often find in children. And it's very characteristic of rickets to see bowed legs. And I'll show you these on these slides. These are going to be bowed legs. This is a very characteristic symptom of rickets. These bowed legs are caused by the inadequate calcification of the growth plate. So these bones sort of grow in this curved manner. We'll also have other deformities that can occur with other bones, but this is one of the major characteristics that we'll see with rickets. Now, osteomalacia is our other condition that we will see in adults. This is often called adult rickets, because they are both referring to the inadequate calcification of bone matrix. So while rickets is more focused on the formation of new bones as we grow, osteomalacia will focus more on bone remodeling. So as new bones are constantly being remodeled, that new bone that's been deposited fails to fully calcify, and this can cause very weak bones and a lot of pain. So if this is caused by a vitamin D deficiency, we're going to treat this with a vitamin D supplement. We might also tell our patients to go outside a little bit more often and get more sunlight. Remember, sunlight is going to help activate vitamin D in the integumentary system. So both of these are prescribed treatments for these conditions. At any given time with bone remodeling, 5% of our entire bone mass is being remodeled. So with osteomalacia, this can cause very, very weak and very frail bones. And you can see osteomalacia in this picture, showing our bones a little bit more flexible than they should be. So it's always important to get outside, get enough sunlight, and also to make sure that you have a healthy, balanced diet. So that will conclude our lecture video for Chapter 6. We'll come back in Chapter 7 and Chapter 8, and we'll actually discuss the specific bones that can be found in the skeletal system.